These deterrent formulations have been actually developed in order to minimize the likelihood that they will be diverted by people who want to get high. They actually, even it's harder to extract the drug from them and then to inject it, which is the way that the way that opioids exert more intense rewarding effects. So that's why that deterrent formulations. There are multiple strategies being done. We know, for example, the opioid deterrent formulation, the new opioid deterrent formulation of OxyContin, has actually seems to be quite effective because we don't see very much a black market for it. We have seen a significant decrease in the number of patients that get it from pill mills or that go for doctors that overprescribe them. So it's actually has been interesting to see that it has made a pretty significant difference in terms of the extent to which OxyContin was diverted. They seem to work. The issue, though, is that not all of the insurances will cover for deterrent formulations. And that is something that is structural in terms of if we are basically encouraging physicians to use opioid deterrent formulations, but your insurance doesn't pay, and they are also more costly because of the cost associated on their development, then we can do all of the science that we want. It's not going to benefit the patients. I think that we need to educate, we need to speak about what are the roadblocks that that we have in our healthcare system that interfere with those physicians doing the right thing. So we know that lack of education is one of the components, but even if you educate everybody, if you don't do some structural changes, that will not help. So it is these two pieces that need to be addressed. It does appear to have, in certain instances, have been the case that a patient goes with severe pain and many physicians refuse to prescribe opioids because they are afraid that they would be actually asked and inquiries from agencies that are surveying this. And some of the process by which they have to enter information and monitoring, for example, if I'm prescribing you an opioid, I need to be sure and assured that you haven't been prescribed an opioid by another physician. And some of those systems to get that information are not timely. It takes a couple of hours, sometimes days, to get that information. In the meantime, my patient is very actually severely suffering from pain. So many physicians actually don't want to prescribe opioids. And that, again, is a negative side, because if you know how to properly prescribe it, and within the context of particularly acute control of pain, they can be extremely valuable. It comes to the point actually that now it's very difficult for patients suffering from chronic pain to get help, because physicians are afraid of opioids on the one hand, and we don't have sufficient alternatives. So opioids is one of the things that we have. And there's fear, right? There's this fear of overdoses that because of what we're observing. These medications, you have to actually prescribe them very carefully and survey and be aware that there is a risk. That you need to try to give the lowest doses you can give to your patient. The other thing that you need to be aware, which is what makes it so difficult, opioids are difficult to use for chronic pain, you become tolerant. So what does that mean? You need higher and higher doses in order to get the same pain relief. And the higher the dose, the greater the risk of overdoses, because tolerance to the effects of opioids do not develop at the same time for all of its effects. For example, people on opioids develop tolerance rapidly for pain, also for its rewarding effects. So when you want to get high on opioids, you need higher and higher doses. But you don't get tolerant for the constipation effects of opioids. And the respiratory depressing effects of opioids appear to develop tolerance at a slower rate that its analgesic effects or its rewarding actions. There has been, initially, most of the concern had been concentrated on the extended release or the long-acting opioids. Now there is also great awareness that we should also be paying attention to the short-acting opioids, that both of them connote different risks. So overall, there are certain extended release opioids that can be beneficial under certain circumstances, and then you have short-acting opioids that could, in some instances, be harmful. It is very difficult to come up with a simple recipe and say you're just going to use a short-acting versus a long-acting. Take, for example, fentanyl. Short-acting, very, very potent opioid medication, very good to actually deal with extremely severe pain. But it can have a role on the treatment of patients that are on chronic pain, where the opioids that are being given actually are unable to control sharp bursts of pain. So you can use it when the pain becomes intolerable for just one or two occasions. So you need to actually tailor your intervention to the patient and the characteristics. And again, CDC, as CDC highlights, we've come to recognize that opioids should not be our first line of treatment for chronic pain, but it should be part of a comprehensive management of pain that will include teaching your patient behaviors that can improve their ability to function properly, teaching them that they shouldn't expect on a scale of 0 to 10 that your medication will do 0, that they learn to live with a certain level of pain, but to try to minimize, because otherwise you end up escalating how much opioids you have, and to use alternative medicines.